Hey guys, my name is Brandon Dice, and today I'll be presenting chronic heart failure disease. So, what is heart failure? It's classified as a condition in which the heart is unable to pump blood at a rate sufficient enough to meet the metabolic requirements of the body's organ systems and tissues. Unfortunately, over 5 million individuals are affected by this disease. Just to give you a general overview, approximately 670,000 new cases are diagnosed annually in people. Due to improvements in healthcare, the aging U.S. population and survival of patients with cardiovascular diseases have increased. What this means is that the prevalence of this disease will only increase over the next 10 years. Heart failure is the leading reason for hospitalizations in those 65 years of age and older. The disease directly and indirectly contributes to approximately 280,000 deaths annually with a 5-year mortality rate of 50%. Its economic burden in the United States has grossed a bill of nearly $32 billion per year. What are the causes for chronic heart failure, you ask? Let me begin by telling you it doesn't occur overnight. It's a result of systolic as well as diastolic dysfunction. Systolic dysfunction may be defined as an inability or decreased ability of the cardiac myofibrils to shorten or contract against the load. Diastolic dysfunction may be defined as a stiff or less compliant chamber which is partially unable to relax and expand as blood flows in during diastole. These two dysfunctions ultimately put a detriment on ejection fraction, which is the percentage of blood that is ejected from the left ventricle per beat. Ejection fraction may be calculated by solving the equation N diastolic volume minus N systolic volume divided by N diastolic volume times 100. What are the symptoms of chronic heart failure? First off, symptoms include exercise intolerance that is manifested by fatigue or shortness of breath upon physical exertion, and additional symptoms include fluid retention as evidenced by peripheral edema, weight gain, or both. On occasion, these symptoms are accompanied by proximal nocturnal dyspnea and orthopnea. Proximal nocturnal dyspnea is referred to as sudden awakening caused by labored breathing. Orthopnea is difficulty breathing while lying supine or flat. Interestingly enough, the severity of orthopnea is rated based upon the number of pillows needed under a patient's head to prop them up so that they can breathe comfortably while recumbent. Chronic heart failure is divided up into 4 stages according to the New York Heart Association. Stage A is considered high risk for heart failure, no anatomic or functional abnormalities, signs, or symptoms. Stage B begins to show structural abnormalities associated with heart failure but no symptoms. Stage C is where you begin to examine current or prior signs and structural abnormalities where heart failure is present. And lastly, stage D is advanced structural heart failure with symptoms at rest despite maximal medical therapy. In order to provide a proper diagnosis of the severity of a patient's condition, the presence and signs of symptoms stated in the past slide must be present, as well as a significantly reduced ejection fraction. The ejection fraction is typically measured with an echocardiogram machine. However, alternative assessments such as radionuclide tests or cardiac catheterization may also be used. In order to help reduce stress and symptoms of heart failure, patients are typically prescribed a combination of several medications. These medications listed all serve different purposes. Diuretics help to decrease blood volume overload in the heart. Angiotensin converting enzyme inhibitors as well as beta-adrenergic blockers decrease heart rate and blood pressure at rest to greatly reduce stress on the coronary system. Angiotensin receptor blockers decrease afterload and blood pressure at rest. And lastly, digitalis helps to prevent heart arrhythmias, thus reducing hospitalization in those with symptomatic heart failure. Some special considerations to take into account before having your patient perform exercise is to ensure the following are in check. He or she should not have an ejection fraction of less than 40% or risk stratification of NYHA class 2 or 3. They should also be receiving standard drug therapy of ACE inhibitors, beta-adrenergic blockade, or diuretics for a minimum of at least 6 weeks prior. After all this is said and done, your patient should be absent of any cardiac or non-cardiac related problems that would limit or hinder any participation in exercise. To put everything we've learned together throughout this presentation, I put together an example case study for the following subject. Subject X is a 58-year-old African-American male diagnosed with chronic heart failure. He is 5 foot 10 inches and weighs 240 pounds. His body mass index is 35.9 and he is classified as obese. His resting heart rate is 74 beats per minute with a blood pressure of 138 over 96 millimeters of mercury, which is indicative of a stage 1 hypertensive disorder. His blood lipid profile shows that his total cholesterol levels are 230 milligrams per deciliter, with his LDLs being at 200 and his HDL being below 30. Upon performing an examination on subject X, a cardiac catheterization revealed the diagnosis of a 3-vessel coronary artery disease. The disease was manifested by a 20% left main lesion, a 95% stenosis in the left anterior descending artery, a total occlusion of the circumflex artery, and a 70% in the proximal right coronary artery. Subject X was diagnosed with mild ischemic cardiomyopathy. It was recommended that he should have a coronary artery bypass. However, he opted out and decided to partake in medical nutrition therapy, lifestyle changes, and cardiac rehabilitation. In order to aid subject X in his lifestyle changes and recovery, his exercise prescription is as follows. He is to perform aerobic activity 60 to 70% of his heart rate reserve 4 to 5 times per week at a minimum of 40 minutes per session. While working with muscular strength and endurance, subject X should focus on utilizing fixed machines as well as some free weights and bands. His training intensity should be approximately 40% of his 1 rep max for upper body and 50% of his 1 rep max for lower body workouts. Last but not least, let's not forget flexibility. In order to improve subject X's range of motion, it is suggested that he participate in 5 minutes of static stretching before and 10 minutes after any aerobic or resistance training workout. It is crucial that he stretches major muscle groups such as the quadriceps and hamstrings to facilitate maximum recovery as well as preparation for activity, and therefore reducing chance for injury. With the use of cardiac rehab, lifestyle changes, and medical nutrition therapy, coronary bypass surgery as well as heart failure defects may be decreased to foster an improved quality of life and a decreased mortality rate. Exercise is medicine, and I firmly believe that every individual should strive to be more active in order to improve their lives. Thanks for listening, guys, and hope you all enjoyed my presentation and learned a thing or two.